Welcome back, everybody. We're going to start the second session with Prof. Yusuf Al-Dibasi, who's going to talk about the prevalence of refractive errors and amblyopia in primary school children in Qassim province.
شكرا دكتور محمد. بسم الله الرحمن الرحيم. Today, inshallah, I will talk about the prevalence of refractive errors and amblyopia in primary school children in Qassim province. So first of all, we give just background about the Qassim, this photo of Buraida city. And Qassim region is the 7th most populated province of KSA, population around 1,455,000. And according to UNESCO in 2007, gross enrollment ratio in primary school is 98.1, boys 99.9, and girls about 96.3. So most of boys, they are going to schools. So children enter elementary education at the age of 6. So the best of our knowledge at that time, there is no data available on prevalence of uncorrected refractive error and amblyopia in primary children in Qassim region. So that's why we did the study, and our study was aimed to determine the prevalence of uncorrected refractive error and amblyopia among primary schools children in different areas of Qassim region, assessing the association between age and gender and these visual impairments, considering both the area and recent reports indicated an association between growth and risk factor of refractive errors. So how we define the uncorrected refractive error? It's as a two-line improvement with refraction in the better eye, or unmet refractive need was defined as having 20/40 vision, whereas visual acuity in the better eye achieving 20/40 or better after refraction. So this is definition 1. And definition 2, having 20/40 visual acuity in the better eye, seeing and achieving at least 2-line better. And we define amblyopia as a corrected visual acuity of better than 20/40 in the affected eye, not attributable to any underlying structures, abnormality of the eye, of the visual pathway, a difference of at least 2 logmar lines between the 2 eyes. So we collect the data from 21 primary school in Buraida and other cities in Qassim region. So we collect about more than 5,000 students. All the schools were comparable in terms of size and curricular and extracurricular activities and the student population composition. In this Christian study, candidates were selected from school registered and included after parent and school authority consent. So these are some photos for our students and staff who are collecting the data at that time. So the prevalence of uncorrected refractive error was shown in percentage, and the prevalence of amblyopia as well is shown in percentage, and we use these tests to do the analysis of our data. So we have seen girls and boys and about equal in size. So children were divided in 2 groups. So we age from 6 to 9 as level 1 or group 1, and level 2 from 10 to 13. Stratification was not done based on educational level, so we concentrate about the age more than education. So here is the distribution of the normal students and also student with refractive error. So level 1 is about 2,244, and in level 2, 1,969. And if you see uncorrected refractive error was 335, and level 2 was 511. So overall, the percentage was 18.6 of. So here it shows the distribution of refractive errors. As you have seen, myopia and myopic stigmatism was the most prevalence of refractive error of our sample. The myopia shows 6.5%. The other graph here shows the age distribution of uncorrected refractive error. So starting from age 6 until 13. And we have seen as myopia and myopic stigmatism is the more frequent. Also, this table shows the distribution of prevalence of different type of among boys and girls, about the 5 types of refractive errors. And uncorrected refractive error actually was 16.3, which is really high. So the main spherical equivalent of refractive error, it shows here in details about the right eye and the left eye for different type of refractive error. Also, this table as well is showing the level 1 primary school and also level 2 in percentage for myopia and compared with hyperopia. The other table here as well is compare the other types, myopic stigmatism and hyperopic stigmatism and mixed stigmatism, which more with different between level 1 and level 2, and also the difference between boys and girls. Also, we have checked the amblyopia as well. So the prevalence of amblyopia was found to be 3.9%, in which the unilateral amblyopia was more prevalent than bilateral amblyopia. The causes of amblyopia were refractive error and strabismus. Anisometropic amblyopia was more frequent as compared to isometropic and strabismic amblyopia. So as you can see, the most frequent cause of amblyopia was refractive error. Also, this table shows about the different type of amblyopia and the causes of amblyopia. Anisometropia is the highest and high bilateral refractive error. Esotropia and exotropia is the least. Type of amblyopia, hyperopic stigmatism, which is the more frequent. So according to WHO, 13 million children worldwide are either blind or visually impaired because they do not have a pair of spectacles. Therefore, screening of school children is an important measure, knowing the magnitude of refractive error and their correction at the appropriate time. So according to the other studies, screening of 5 to 15 years old yield the most health effect and most absolute terms. Thus, screening of both 10 to 15 and 5 to 15 years old is very cost-effective strategy, and our current study is the first to carry out an investigation into the prevalence of refractive error using larger sample of size, which is more than 5,000 subjects in Saudi Arabia. So we found that 81.4% the screened children were normal, and the overall prevalence of refractive error was 18.6. Studies have shown that the overall prevalence of refractive error among primary school children was 13.7 in Al-Ahsa, and Qatar 19.7, and in Egypt 21%, and Uganda 11.6, and other, we quote other benchmark to our study. Myopia and myopic stigmatism was the most common uncorrected refractive error seen in our study. So the prevalence of myopia in Qassim region was found to be consistent with the prevalence reported in Hong Kong and China and Singapore. Possible causes of such finding regard myopia might be as a result of more time spent on near work and less time in outdoors, consistent with the report that higher educational level and parental history of myopia increased the risk of myopia. 87% of myopic students are mild, 10% with moderate myopia, and 2.1% with severe amblyopia. Thus, the low myopia was the most prevalent uncorrected refractive error in primary school children. Our results show that there was a significant higher prevalence of myopia among girls compared to boys. The girls was 1.59 times more likely to have myopia than boys. Similar finding was reported in Kashmiri school children in India and Hong Kong and China and Taiwan and Germany. So we found a significant higher prevalence of myopia and myopic stigmatism among the level 2 students compared to the level 1, which is all older students. With the increased level of education and age, there was steady increase in myopia and myopic stigmatism. Level 2 students were found to be 3.5 and 1.84 times more myopic and myopic stigmatism, respectively, than level 1 students. Consistently, Fan et al. And Ahmed et al. Have found positive correlation between prevalence of myopia with age and higher levels of education, because students in higher class tend to spend more time studying. Consistent with our report, reported that myopic stigmatism is the most common cause of poor VA, as subjects with induced myopia stigmatism couldn't accommodate to bring the more myopic meridian into better focus relative to hyperopic and mixed stigmatism. So here is other studies in Saudi Arabia. Our study is the first line of amblyopia. You see here 3.9 in our study, and in Al-Ahsa is 3.3, in Riyadh 2.6, Abha 1.9, and 1.6 in Al-Baha, and Jeddah is 1.3. All these are very old study actually compared to our study. And this is the other result from other countries. Australia and USA and Canada is very high in Canada. So all is less than our study, except in Canada are higher. So our recommendation for finding of these studies actually need for an ongoing refractive error screening in primary school students, implementation of a child eye health program for an effective and sustainable delivery of eye care, performance of periodical vision screening throughout childhood, cost-effective approach for early detection of visual impairments. So we conclude that refractive error in school-age children is an important public health problem because it has substantial impact on learning capabilities and educational potentials in children. The data suggests that we need periodic vision screening for refractive error in primary school children in Qassim province, considering the fact that the prevalence of uncorrected refractive error, especially myopia and myopic stigmatism, were relatively higher when compared to other regions. So these are references that we use, and we'd like to thank you for your kind attention.
Thank you, Prof. Yusuf. The topic is now open for discussion and questions. We have time for just 2 quick questions. Any questions?
Thank you, Professor Yusuf. Without is this study, have we done cyclopentalate or just normal refraction for children?
No, actually, we do cycloplegic refraction. Yeah. We have done cycloplegic refraction, and we use cyclopentalate 1%.
Any other question?
يعطيك العافية دكتور يوسف. بالنسبة للإحصائيات للميوبيك استجماتيزم والميوبيا بريفلنس، يعني ما فكرتوا تجمعونها على أساس تكون الدراسة defined as myope, hyperope?
دكتور سليمان, English please.
Sorry. Why you didn't classify myopic group as myopic stigmatism and the simple myope to be one group, like we do in most of the study? They do spherical equivalent, so this would be easier to classify myopic and hyperopic. يعني why you didn't think about instead of having 5 groups, just 3 groups like myope, hyperope, and
yeah, thank you very much. Okay, we try to be in details, so that's why we make it 5 groups to know which is the most prevalence of kind of refractive errors. I mean, it's easy now. After we did the details, we can combine it together, and we know the prevalence. But we found this myopic and myopic stigmatism is the most frequent prevalence among our studies.
Thank you, Professor Yusuf. And our next speaker is Dr. Sulaiman Al-Dakhail, who's going to talk about myopia control.
Welcome to everyone. Today our talk is about myopia control. First, let me outline the main points that I'm going to cover in this talk. We'll talk about the prevalence of myopia globally. Then we'll talk about the risk factor of myopia. Then we'll discuss the metrobization and the development of the visual system. Then we'll evaluate the visual optics theory on myopia progression. After that, we're going to talk about the prevention strategies and methods to control myopia. And at the end of my talk, I will talk about the role of our department in the community eye health. Myopia is defined to be minus 0.5, equal or minus 0.5 in either eye. Myopia is one of the most prevalent eye disorder around the world. And according to Brian Holden Institute, they projected that in 2050, around 52% of the world population to be myopic. And here are some of the stats. As you see, the prevalence of myopia in Canada to be 72%, in the United States 41%, and a recent study in Saudi Arabia in 2018, according to Dr. Al-Sagar in the King Saud University, they found that the prevalence of myopia to be 53% in the age group from 12 to 20. However, the highest prevalence number of myopia is in East Asian parts of the world. In China, 95%, Singapore, 96%, and South Korea to be 81%. So we know that the socio-economic impact of myopia is tremendous, and they expected that each Singaporean school children costing $150, and in the United States they projected that the annual direct cost is between $4 to $7 billion a year. So in our society, when we have a lot of high myopic individuals, we'll expect to have complications like cataract, glaucoma, macular degeneration, and retinal detachment. And this for sure will impair the quality of life, and will impair the education achievement for school children. This will also cause a burden in the global eye service, as we have a lot of high myopic individuals. It will increase the number of pathological diseases, and also will increase the number of visual impairment individual, and this will cause a burden in the ophthalmology clinic and low vision service. We know that myopic is genetic, and many studies have confirmed that when you have both parents are myopic, the percentage will be high compared when you have one myopic parents or non-myopic parents. And here are the sums of the stats according to many well-conducted study in the table. The environmental factor is also another association, possibility that could increase the number of myopic subjects. And near work has been mentioned like 150 years ago, and a study has been conducted in Singapore and Sydney. They examine school children from Chinese ethnicity, and they found that the prevalence of myopia is high in children in Singapore compared to the same children who lived in Sydney, and despite they share the same genetic profile. And many studies have reported relationship between near work and time spent outdoor in myopia progression. But there is no agreement between these studies about which specific environmental factor. We know that children who lived in rural area have lower prevalence of myopia. In China, they reported that 19% of children who live in city have myopic, whereas 6.6% in the countryside. In Al-Ahsa, they reported the prevalence of myopia to be almost 16% in the rural, in urban cities compared to 9% in the rural area. So this would raise a question whether the outdoor places when the children have open field area would play a role in the prevalence of myopia, but still we don't know either it's outdoor activity or time spent on near work. Evidence from many animal studies have pointed that visual experience during development of refractive error is very important. And scientists have examined, sorry for the messy diagram here. Scientists have examined chicks and monkeys, and they use minus and plus lenses to manipulate the refractive power of the eye. So when they place minus lenses, they found that the eye grow so fast and rapid compared with plus lenses. And this is thought to be due to hyperopic blur defocus. As you see in the diagram, the image with the minus lenses will be projected back to in the back of the retina, and this would be like a stimulus for eye growth, whereas plus lenses would make the image falling in front of the retina and will be no stimulus for eye growth. Most of the current theory about myopia progression are based on consistent finding from animal study that hyperopic defocus caused eye growth and myopic defocus slow the eye growth. As you see the diagram showing how the myopic and hyperopic defocus will play a big role in the development of the eye. So we know from studies that myopic patients have more hyperopic focus in the periphery compared with imetropic and hyperopic subjects. And this is MRI slide showing how the myopic eye is different than imetropic eye in the peripheral area. Also, near work aberration has been studied in different refractive group. Study have found that myopic have a greater level of higher order aberration following reading. The final theory is about lack of accommodation. Guizda in 1993 found that myopic subjects have lack of accommodation during near work compared to imetropic subjects. And this would create hyperopic defocus during near task, and this is thought to be stimulus for eye growth. You see in the diagram how is the target when the patient's looking at near distance, for example, 50 centimeter. So he would require 2 diopter accommodation. So Guizda found that myopic subject cannot produce 2 diopter accommodation. It's like 1.5 or let's say 1 diopter. So that means the image will fall behind the retina, and this lack of accommodation would be a stimulus for eye growth. And you see in this diagram showing how the lack of accommodation is causing eye growth because it's like a kind of stimulus for eye growth. As 0.5 or 1 diopter during the near task, it's like the image would be require +1 to bring the image back from the back of the eye to fall exactly in the retina. So that 0.5 diopter sphere would be stimulus for eye growth, and this would make the myopic subject progressing too fast during the childhood. Now we'll talk about the prevention methods about myopia progression based on the previous theory, lack of accommodation, peripheral refraction, and near work aberration. So the first method, which has been studied long time ago, under correction of myopia, and scientists also used atropine drops to control myopia, and they use optical correction, including spectacles, multifocal, bifocal lenses, and also they used dual focus, multifocal contact lenses, and they used ortho-K. So the under correction is the aim of the under correction myopia. So when you have -4 patients, you prescribe -3.5 or -3. It's like you make the myopic under corrected by 1 or 0.5 diopter sphere. So the aim is to reduce the lack of accommodation by reducing the accommodation demand at all distance. So the child will not have any lack of accommodation during near work, as he is already having +0.5 during near task. So we will exclude the effect of lack of accommodation by prescribing less spherical correction for distance and near. But there is no agreement between study about the effectiveness of these methods. And one study have found that 94% participants showed more rapid progression with myopia. The second method is using atropine. As you know, the atropine is used to relax the accommodation system. And studies have found significant effect of using atropine in reducing the progression rate of myopic children. Atropine can be used in 2 different ways. We have the high dose and the low dose. High dose 0.5 to 1%, lower dose 0.01 to 1%, 0.01%. Recent studies have been conducted to compare both concentration to see the effectiveness of using these drops. And they found that using lower dose of atropine also achieve significant reduction in the myopia progression with a minimum side effect. So now we'll move to the spectacles, which include multifocal and bifocal glasses. Again, this method had been studied a long time ago, and study have found variable results, and over a long time they used multifocal glasses and bifocal glasses, and the reduction was about 0.5 diopter sphere over 2 years period. A recent study as well from Guizda found that using multifocal glasses have achieved only 0.2 diopter sphere. So we cannot rely on this method to control myopia because the number is very low. It can be statistically significant, but clinically not significant, and cannot be used in the future to implement this as an effective treatment. Now we'll move to the contact lens method. By using multifocal, as you see in the design, the center has clear distance for correcting the distance refraction, and the plus in the periphery in the blue area, where the plus add, you can use plus 2.5 or plus 3 add. The idea, you can see it in figure 3, is to bring back the peripheral image to fall in the retina or in front of the retina. And in the lower 3 diagram showing how the uncorrected myopia with the traditional correction in the middle image, in the bottom, in the middle image, you can see that still the periphery with the spherical correction, the image will project it back behind the retina, and this would cause stimulus for eye growth, but with multifocal lenses, the image will be corrected and focused in front of the retina. Now we'll illustrate some of the studies that used multifocal lenses. In Sydney, they used multifocal bioinfinity plus 3, and the reduction was quarter over 1 year period, but they didn't measure the axial length and either the accommodation response. Philips in New Zealand have examined the myopic subject by using concentric design of multifocal, and they found also quarter difference in the mean spherical change. And again, they didn't measure the axial length, and the change was slightly small. The accommodation response was vary between 2.7 to 2.75, and this is due to the power profile of the contact lens. As you see in this image, the power profile is like the pupil size will play 1 minute. Okay, the power profile across the contact lens will change according to the lens design. The final method is using the orthokeratology. We know that using hard contact lens to reshape the corneal surface, it's very effective, and recent study have found that after 2 years of using orthokeratology, the myopia reduction has achieved significant results with the mean change equivalent to 0.6. So I would conclude that using ortho-K and atropine is the most effective method. So at the end, we'll talk about our the optometry department has opened now in the Qassim Medical City, different clinic for adults and for children, and we are now having pediatric eye clinic. It's in Tuesday afternoon, and we see any child with visual problems like amblyopia, and we do control the myopia progression for those children, and we do orthoptics workout, and we are happy to receive any child with visual problems. And this is my end of my presentation. Thank you very much.
Thank you very much, Dr. Sulaiman Tkhayil. This topic is open for discussion. We only have time for 2 quick questions. Dr. Nabi, you have the mic, Dr. Nabi.
It was very informative, and yeah, I just have one question. Is you said about lack of accommodation. It is the stimulus for myopic progression, which is about 0.5 diopter to 0.75. But this is very commonly seen in every individual, the lack of accommodation. So how we could justify that this lack of accommodation is stimulus for myopia? If that's the case, it should be happening almost in all individuals.
Sorry, can you repeat the last part of your question?
The
You talk
lack of
about the lack of accommodation?
Yeah, the lack of accommodation around 0.5 to 0.75 diopters
Yeah.
is normal for most of the children,
Yeah,
or even most of the adults, it means.
yeah.
So how we could justify that lack of accommodation is
It's
a
causing
stimulus?
myopia progression.
Yes.
Yeah. According to Gwizda study, she found that when she examined the lack of accommodation to different refractive group like hyperope, imagerope, and myope, and they found that most of the myopic children, they have lack of accommodation compared to imagerope. So the lack of accommodation is revealed in myopic group, and they think that this is the trigger for or the reason for the progression of myopia. So it's like another study by Dr. Seidel, he done it in 2003, and Dr. Amari in 2008. Also, she found myopic subject always have lack of accommodation compared to a different refractive group. So they think that this is maybe the reason for myopic to progress compared to other children who don't have myopic.
Your observation in terms of lack of accommodation, have you not seen lack of accommodation in hyperopic or other subjects?
Yeah, but it's vary. I think it's vary between different refractive group. We can't classify lack of accommodation to be fixed in all the refractive groups. So they think that myopic they are more vulnerable to.
Okay, thank you.
Thank you so much. Okay, one more question. Quick question, please.
Thank you, Dr. Suleiman, for your presentations. Just my questions is the lead of accommodations and high AC over A ratio. Yeah, could lead to development of myopia or lead to progressive of myopia?
Some study they mentioned that could affect the myopia progression if the child has a high AC ratio or having. But for myopic group, I disagree with you because it's like most of the literature they didn't mention that myopic have lead of accommodation. They all in agreement that most myopic have lag of accommodation. We know that when the child have -3 or -2, he don't require even glasses to produce accommodation. So the near viewing is clear for most of myopic. So you hardly find myopic with lead of accommodation. Yeah, but could be the high AC ratio could play effects on that.
Thank you very much, Dr. Suleiman Khail. Our next speaker is going to be Dr. Saif Rashid. He is going to talk about the childhood eye care in developing countries.
Hello, everyone. Thank you for allowing me to present my topic. My topic is childhood eye care plan for developing country. Globally estimated indicates that more than 19 million visually impaired children worldwide. Of those, 1.4 million were blind and about 17.5 million have low vision. Most of these children living in developing or poor nations. WHO indicates that more than 80% of childhood visual impairment is treatable by early investigation at community, primary, secondary, and tertiary level. As you know, childhood visual impairment have impact on whole life of children, and the children have long life if compared to old people, because visual impairment on children have huge impact of whole of the children's life. Some study indicates that children die within 1 year of being blind because visual impairment have impact on whole life of children. Childhood visual impairment in low-income countries is the one of key component of major global prevention of avoidable blindness initiative Vision 2020. A visual impairment among children is less common than adults, but have huge impact on education and social life of children and could lead to poverty. Many studies conducted on visual impairment and refractive error indicates that childhood visual impairment is a major global problem around the world, and some study indicates that the uncorrected refractive error is the leading causes of visual impairment globally. Our aim of this lecture to develop child eye care plan for delivering a comprehensive eye care service in developing country. In this study, we use sample from 2 developing countries. We use sample from Sudan and other sample from Somaliland. The sample is for school-age children, the age between 6 to 15 years, and all this is school-age children. The total sample of the study is 1,775 from Sudan and 1,204 from Somaliland. The age from 6 to 15 years, but there is a small difference in mean and standard deviations. In Sudan study, the prevalence of myopia more than 0.5 or greater was 6.8. Hypermetropia more than 2 diopter was 1.9, and astigmatism more than 0.75 was 2.5. The prevalence of visual impairment due to myopia was associated with the increased grade level, but was no significant difference in prevalence of visual impairment between male and female. The causes of childhood visual impairment in Sudan, as you can see here, the leading causes of visual impairment in Sudan was uncorrected refractive error, followed by retinal disorders. In Somaliland, the prevalence of myopia was 0.5, equal or more than 0.5 was 9.1. Hypermetropia more than or equal 2 diopter was 2.7, and astigmatism was 3.9. The prevalence of visual impairment because of refractive error was associated with the increased childhood age, but not significant difference with gender. The causes of childhood visual impairment in Somaliland, as you can see here, the leading causes of visual impairment was uncorrected refractive error, followed by amblyopia. The conclusion from the previous study, we see the leading causes of visual impairment in this country was uncorrected refractive error and amblyopia. Most of causes of this visual impairment could be preventable or treatable. We develop a childhood eye care plan or childhood eye care model for delivering a comprehensive child eye care plan for this community. We develop a model for 3 levels. For example, here, the school level, primary level, and secondary level, and tertiary level. Here in the school level, we need to deliver eye health educations and vision screening and school vision screening. We need to deliver here eye health educations because most of causes of visual impairment could be eliminated by increased awareness of community. We need to increase the awareness of teachers and students here to be more aware about signs and symptoms of uncorrected refractive error. And also here we need the service delivered at the school level. Here, who delivers this service? The school teachers or community health workers. In this level, we need school teachers or community health workers to deliver this service. This service delivered at level of school. The second level is the primary level. In this level, we need to deliver eye examinations and refractive error corrections. This service should be delivered at health centers or optometric centers. Optometrist or primary eye care worker could deliver this service. This service should be delivered at the community level, at the town or village. The third level is secondary level. This we need to deliver at this level service such as the diagnosis and management of eye disease. This service should be delivered at local hospital. The service should be provided by ophthalmologists, orthoptists, and low vision specialists. This service should be delivered at the province level. And final level is a tertiary level. This level for complicated eye disease. This level for complicated eye disease and rehabilitation and surgery. This service should be at the district hospital. This service should be provided by pediatric ophthalmologists, optometrists, and low vision specialists. This service should be delivered at district level. And also we develop model for childhood eye care training need. This staff, we need training for him. For example, here for the school level, we need to train school teachers and community health worker for vision screening and health education. Just here we need to train school teachers and community eye worker for vision screening and eye health education. The training site should be at local school, just as the local school. In primary level, we need to train optometrists, primary eye care worker for eye examinations and refractive error corrections. The site for this training should be a school of optometry. The secondary level, we need to train ophthalmologists, orthoptists, and low vision specialists for diagnostic and management for eye disease. The training site should be a local hospital. At the tertiary level, we need training for pediatric ophthalmologists, orthoptists, low vision specialists for managing complicated eye disease and rehabilitation. The training site should be at district level. Our conclusion, the study concludes that uncorrected refractive error was the major causes of visual impairment among school-age children in poor nations. This finding indicates that an urgent need for developing a comprehensive child eye care plan for delivering eye care service. This support need for regular vision screening program for preventions of avoidable causes of visual impairment through timely diagnostic and treatment of childhood eye problems. This is my reference. Thank you.
Thank you very much, Dr. Saif. This topic is open for questions.
Thank you, Dr. Saif, for this presentation. I just have one question about the eye surface for, can we apply this model, for example, here in Saudi Arabia, or this is like in some part of developing countries? Can we compare this to our system here, our health system?
Yeah, this we suggest model. We can modify a model according the country needs. Just we develop this model for developing country. You can modify this model as you can need.
Okay. Thank you.
Thank you, Dr. Saif. Speaker is Dr. Goodwin Ovensri. He's going to talk about knowledge, attitudes, and practices of optometrists in Saudi Arabia of low vision.
Good morning, everybody. My presentation is knowledge, attitudes, and practices of optometrists in Saudi Arabia with respect to low vision. And while Dr. Waleed was making his presentation, he did mention some of the strategies to improve eye care services in the country. One of the things he said was that, doing a situation analysis to know the gaps that exist so that we're able to fill this gap. And one of the reasons we looked at this was if you want to establish a low vision service, either at this center or in the country, you needed to know the personnel that are involved, who are expected to provide this service, and to what extent they are providing this service. Now, on Thursday, the last week Thursday, marked World Sight Day. And it's a day to draw attention to visual problem, the problem of blindness and visual impairment in our world. And the theme of that day was Vision First. Now, Vision First, the implication was that for everything you do, we couldn't have been here this morning independently without the use of our sight. Now, oftentimes, when people present with eye problems, sometimes they present late. For example, I've heard about diabetic retinopathy. By the time they are presenting, it's probably late, and then they probably would have developed low vision. And so what do we do with this category of people. So it is important for us to, while looking at these problems that causes visual impairment, let us also look at all the things that will follow if this problem persists and then eventually results to low vision. Now, we'll quickly look at the state of low vision in Saudi Arabia if we want to know, what is the situation. Now, this publication was done in 2006 by Al-Otaibi, and I will read out the underlined portion. The study found out that 75% of low vision cases was handled by ophthalmologists and 25% by optometrists, although many have not undergone specialist training in low vision. Now, what that indicates, don't bother about the personnel that provide the service, but what that indicates is that what probably constituted provision of low vision service is the handing out of handheld magnifiers. A patient present with low vision, you've done refraction, you couldn't help, you've done medical and surgical treatment, there's still residual visual impairment. And so you just hand out a handheld magnifier to enable the person to read. That does not constitute low vision. So that was the state as of 2006. Now, in some 10 years later, he did a study, and this is what he came out with. A retrospective study, of course, of low vision in Saudi Arabia. And to justify the point I just made, we found out that the most prescribed low vision devices, this study was done in one facility, so it is probably not representative of the whole country. But it is indicative because where this study was carried out, the I World Medical Complex is a tertiary facility with supposedly provision of low vision service. And this is what is provided. The most prescribed low vision device is handheld device. And of course, that underscored the statement I just made that low vision service was just handing out of handheld device to, people with low vision to enhance their ability to read. And the causes of visual impairment are indicated in the slide. So what's the justification for this study? Given the poor state of low vision service practice in Saudi Arabia, it was necessary to investigate the knowledge, attitudes, and practices of optometrists regarding low vision practice and to elicit barriers to low vision services in the kingdom. This knowledge will be useful in addressing the gap already identified, namely, very few optometrists provide low vision services in Saudi Arabia. So we wanted to find out the optometrists that have been trained in Saudi Arabia, who practice in Saudi Arabia, what is their knowledge of low vision, what do they do about low vision, and to also identify the barriers that they probably are encountering in the course of their practice. So the aim of the study was to investigate the knowledge, attitude, and practices of optometrists in Saudi Arabia regarding low vision service. Now the methodology, we did it was more like a case of fishing for error. So it was a small-scale study, and we did a very basic cross-sectional survey where we sent out questionnaire. The questionnaire was sent out electronically. We did a Google form and sent it to optometrists who are practicing on the mailing list of the Saudi Optometric Association. And we used other means, social media, WhatsApp, to send to colleagues who will have their details. And so we also expect that completing this questionnaire will imply that you have given consent to participate in this study. Now the results. Now, of all the people, we had about 49 optometrists responded to this questionnaire. 15% were female and 34 were male, and they were aged between 24 to 50, and that was a very active practice period. And the mean age was a little above 31 years. The males were significantly older than the female practitioners. Now, there were 79.6 Saudi nationals and 18.3 foreigners. One person did not indicate whether it's a Saudi or a foreigner, and so couldn't place that person. And if respondents are practiced for between 1 to 26 years. Now, the qualification of the respondent, you'll find out that a large chunk of them, my slide has been turned to Arabic font. Okay, I'm sure all of you will know that percentage. The yellow slide there. So that's a large chunk, okay, and have ODs, and they also have some with bachelor's degree, and there was one person with optometric technician. This is just an aside. I think for an association or for a profession, it is important that in a country we have uniform minimum qualification. So if we're all moving up to OD, it is important that whatever needs to be done to ensure that everybody is at that minimum entry level. And of course, we have some with master's degree and PhD as well who responded to this questionnaire. Now, of these 49, 51% have not had any additional training in low vision beyond the undergraduate course, low vision course that they had. 19 have had workshop trainings, and now we couldn't place this kind of workshop, whether it is a short course or maybe during a conference like such as this, you attend a 1 hour, 2 hour workshop, and so we couldn't tell the adequacy of that level of training in low vision. 5 persons, that's about 10%, indicated that they have had a higher degree or diploma training in low vision. Now, these are the knowledge they reported. Now, we ask certain questions and require them to just indicate, depending on the nature of the question. And the first point there is the VA cutoff for low vision. Now, the VA cutoff, as specified by WHO, is 618. We found out that over nearly 70% or more do not, have that or know that cutoff point for low vision. Now, what that means is that either patients are wrongly diagnosed to have low vision. If you present, for example, we say, okay, if you have 612, now those people will be referred for low vision service, whereas they actually do not have low vision. And then the one that is second, the 33%, which they said, okay, when you have 660 vision or worse. Now, that will lead to, a late referral, so that these people, you are waiting for them to have 660 vision before they are referred for service, which, of course, indicated poor knowledge. We also looked at whether they have an idea of visual field constraint in defining low vision, and 34, which is about under 70%, reported that a constricted visual field could be an indication of low vision. Now, we also asked whether defining low vision implies that you have done your refractive service, you have done your medical service, and your surgical service, and there is still residual visual impairment of visual acuity of 618. I found that only 19%, which is 38, which is also quite low, indicated that that is the position. Now, in terms of practice, and this is very critical, patients with low vision are blind, so nothing much can be done. That was reported by 91% of optometrists. Now, the implication of this is that when a patient presents to your clinic and you've assessed this patient to have low vision, you conclude that this person is blind and so does not require low vision service. And oftentimes, these people are sent to school for the blind. Studies have indicated across various regions of the world that over 50% of children in school for the blind need not be in the school for the blind, because what they require is a simple refractive error correction, probably very high refractive error. And I've had instances of this. We saw a young man about 25 whose refractive error was minus 16 diopters, and this person was in the school for the blind. We went out on an outreach. We examined this patient. The eyes were normal. We did refraction minus 16. At minus 16, the vision came to about 612 plus, and he could jump around. But this person had been in the school for the blind and was living among school for the blind. So this person could have had a normal routine, go through regular school without being confined to that environment. So I think this is also something that we need to address. Now, they also reported that low vision is time-consuming. That we agree to. But then, that is not good enough a reason not to practice low vision. So that represents a poor attitude of optometrists to low vision service. Now, others also indicated that optical low vision devices does not help. Now, good enough, this would also indicated this in green. Most of them, again, over 90% indicated that low vision devices does help low vision patients. Now, they also indicated that low vision are expensive and low vision practice is non-profitable. And of course, in Saudi Arabia and everywhere in the world, you want to be in business to make profit. And we always want to measure profit in terms of how much comes in. And as somebody who has been practicing low vision for quite some while, the satisfaction you get when somebody walks into your clinic and this person has been told 2 years ago, 3 years ago, 5 years ago that, oh, sorry, nothing can be done about your vision. And you're able to assess this person and provide a device, a handheld magnifier, a spectacle magnifier, an electronic magnifier. This person who could not read previously is able to read. The smile on that person's face is worth so much, and I've derived so much satisfaction whenever I achieve that objective. Now, in terms of practice, over 80% of the respondents indicated that in the course of their practice years, they have encountered patients with low vision. And of these, again, almost 80% of them do not provide low vision service, which indicates that provision of low vision service in Saudi Arabia is quite low, and we need to do something about it. Who will do something about it? Not the patient. We, the practitioners, optometrists, needs to do something about this poor service provision. Now, in terms of whether they know any clinic or whether their clinic where they work provide low vision service, we indicated the percentage there, and the other information are there. And I have 1 minute when I'll be done in that time, I hope. Now, in terms of barriers to low vision, the leading barrier that was indicated by a respondent was insufficient training. And that's almost 40% of them indicated that they don't have sufficient training to provide low vision. And closely allied to that is unavailability of low vision devices. And that's over 50% as a barrier. And so we need to identify these barriers and begin to address them. Quickly, we discuss this. Now, despite the fact that all optometric training institutions, KSU, Qassim University, we have a curriculum in low vision. We take a course, at least a one-semester course in low vision. In spite of that, more than 2/3 of the respondents still do not know the WHO cutoff point for low vision. And so we need to look at what we are doing. The identified barriers and the poor attitude to low vision practice have their implication for service provision. Poor diagnosis due to lack of appropriate knowledge of what constitutes low vision. Poor low vision services due to perceived insufficient training, unavailability of low vision devices, and reduced referral rates. If you cannot make a complete diagnosis of a condition, chances are that you are not going to refer these persons. So what do we recommend? Training institutions need to review their low vision curriculum to make it more practicable for graduates to have a better understanding of low vision services, and then create opportunity for organizing retraining in low vision for practicing optometrists. And we also want to recommend to the Saudi Optometric Association that they should take proactive steps by organizing appropriate training workshops to address the identified gaps. Now, in rounding up, I'll just give us a quick situation report in what happened in Nigeria. Prior to 2010, for a population of 160 million or thereabout, there were 3 identified low vision centers in Nigeria where low vision services are provided. One was in the university where I trained, one was a mission hospital in the north of Nigeria, and a private clinic, just 3 facilities that provide low vision service. And then there was a 5-year low vision training workshop that was done for ophthalmologists, optometrists, and ophthalmic nurses for 2 weeks intensive training. And since after that training, the number of people providing low vision service has improved, and patients with low vision now have at least fairly large access to low vision services. Thank you.
Thank you very much, Dr. Goodwin, for a very nice presentation. We're open for a few questions before we go for lunch break. Any questions?
Assalamu alaikum. Thank you for the good presentation. as you know, rehabilitation also needs for co-workers. So we have to train, or low vision practitioner has to train those co-workers. This is one of the barriers. I think it should be meet a lot of tension. Thank you.
Yeah, I do agree with you. I think that's a contribution. Yes, now low vision and then rehabilitation is a continuum. Now what we are saying is that we need to do the low vision first before we even begin to think of rehabilitation. Because if you have not done low vision and then people with still residual impairment before we, I think as a country and maybe as a department of optometry, we can begin to think of how to evolve and create that that bridge between clinical low vision practice and then rehabilitation.
Thank you, Dr. Kadwini. It's an excellent presentation. My question is how to encourage more new optometrists to be or to include low vision practice in their practice, daily practice.
Okay. Now, during the workshop, my first slide talks about how I dabbled into low vision. I'll just give a preview of it. I accidentally jumped into low vision without knowing. And it started in my final year when we were asked to choose a topic of interest and present a seminar on it. And I had a classmate whose father just came from the US and came with some textbooks. So I borrowed this low vision textbook from her, and then I was just going through and I saw something about low vision. And so I said, okay, this is probably an area that most people don't talk about. So I did my seminar on electronic magnification system. And then I made that presentation. And in the course of presenting that, making that presentation and reading about it, my interest began to grow. And then subsequently, I dabbled and eventually. Now, to be very frank, if we need to encourage us to get into it, we need to ensure that our curriculum right from school, apart from emphasizing primary care, must also emphasize some of these specialty areas, and they begin to make people get interest in these specialty areas. Yes, people are interested in contact lenses because of, the finance. Like we said, one of the drawbacks in low vision is the fact that, it takes so long. You probably will need 1 hour, 2 hours to assess a low vision patient. But then the passion, the joy you see when you make somebody who couldn't see to be able to see, I think is enough impetus for us to get into low vision.
Thank you very much, Dr. Goodwin. And now it's break until 1 o'clock. We're going to meet again the third session, inshallah, at 1 p.m. here. Thank you.